Good afternoon, everyone. We are Group 15 and I'm Crystal. Our group topic is osteoporosis in women after menopause. Here is our content. Osteoporosis is divided into two types that are post-menopausal and age-related osteoporosis. We will focus on type 1. It is a metabolic bone disease which is caused by decreased bone mass and progressive deterioration of bone tissue. Bone mineral density is related to T-score. If T-score is equal or less than negative 2.5, it means osteoporosis. Menopause is regarded as a cessation of menstruation. It usually occurs after 40 years old. Ovary produce the female hormone called estrogen. Its function degenerates in menopause and production of estrogen decrease. In below figure, you can see the estrogen remains high before menopause. It decreases significantly after menopause. Osteoporosis is an important issue for women because the great evidence illustrated postmenopausal bone loss is related to menopause. 10% of women who age 60 suffer from menopause in the world. It identifies osteoporosis is a common disease in population. The risk factor of osteoporosis is the deficiency of calcium and vitamin D, pregnancy, as well as alcoholism. Concerning the etiology, postmenopausal osteoporosis is mainly caused by estrogen deficiency. Its level will decrease after menopause. Estrogen deficiency will bring about the postmenopausal osteoporosis. There is an imbalance of bone formation and resorption. The bone resorption is greater than the bone formation and influence the bone loss. Osteoporosis can be reversible and prevented before and after menopause. Bone metabolism mainly involves two osteokinase, that are osteoblasts and osteoclasts. Osteoblasts take part in bone formation. It secretes OPG and RANKL. Bone modeling is simply divided into three phases. Firstly, received by the hormones or signal in some injuries or tumor, then bone reabsorption by osteokinase. Finally, bone formation by osteoblasts. This is a cycle for bone metabolism. Estrogen is a female hormone. It plays a vital role in bone metabolism, which stimulates osteoblasts to produce OPG and cause osteokinase apoptosis. Now, I will pass the time to Nicole to talk about the following.
Thank you, Crystal presentation. The RANK-RANKL OPG system has a significant effect on bone cell activity. Before I introduce the function of the system, in order to make the presentation more clearly, I would like to describe the RANK as K, RANKL as L. First of all, K is the receptor of osteoclast precursor. It will inhibit the osteoclast apoptosis. It prolongs the survival of osteoclasts. Secondly, L is the osteopath immature precursor. It is necessary for osteoclast development. When L binds to K, it will activate the osteoporosis. Therefore, it will differentiate the osteoclast precursor into a major osteoclast. OPG is produced by osteopath. It is an alternative binding receptor for L. The optimal condition is OPG bind to L. It can prevent L bind to K, therefore decrease the L-K interaction. It is clearly so that L-OPG ratio is important determinant of bone mass. The optimal condition is OPG bind to L. Before menopause, sufficient estrogen level can promote the osteoclast apoptosis. It also stimulates osteoblasts to secrete OPG. It's responsible for binding to L. Under the adequate number of OPG, it can increase the OPG bind to L. The ratio of OPG bind to L is greater than L bind to K. It prevents the interaction between L and K. It also inactivates of osteogenesis. The activity of osteoblasts is active than osteoclast. Therefore, the bone formation is greater than the bone resorption.
Besides KLOPG system, other related factors will affect autoclast and autobus activities. Before menopause, ovary produce sufficient level of estrogen. It stimulates anti-inflammatory cytokine production. For example, transforming growth factor beta and interleukin-10. Transforming growth factor beta facilitates the proliferation and differentiation of autobus in interval with estrogen that enhance the bone formation. On the other hand, interleukin-10 inhibits the autoclast the proliferation and differentiation, then decrease bone resorption. Due to enough estrogen enhanced secretion of anti-inflammatory cytokine will support the bone formation more than bone resorption. It maintains the normal bone material density.
After menopause, only the insufficient production of estrogen, it decreases the osteoclast apoptosis. Secondly, it also increases the cytokine secretion that will increase the level of K and lower level of OPG. The number of OPG will be decreased because the estrogen is decreased. Therefore, the ratio of K bind to L increase and the ratio of OPG bind to L decrease. It promotes the interaction of L and K and increase the activation of osteoclastogenesis. The activity of osteoclast is active than osteoblast, so the bone formation is less than bone resorption.
After menopause, ovary function is decreased, then produce inadequate estrogen. Macrophage coronary stimulating factor is a factor to promote autoclast survival and differentiation. Insufficient estrogen level decrease in inhibition, which stimulates autoclast activities. Moreover, is decreased release of anti-inflammatory cytokines, for example, transforming growth factor beta and interleukin-10. Decreased release of transforming growth factor beta is promoter of autoclastogenesis that enhance the bone resorption. On the other hand, decreased release of interleukin-10 will reduce the bone formation. Due to inadequate estrogen level, will decrease secretion of anti-inflammatory cytokine and promote coronary stimulating factor activities that enhance the bone resorption more than bone formation. It increases the loss of the bone mass and enhance the risk of osteoporosis. Let's pass the time to Sally to talk about the signs and symptoms.
Thank you, Wendy. At clinical manifestations, osteoporosis occurred in bone loss begins by the bone breakdown and decreased levels of the bone formations. The tuberculosis of spongy bones will become thin and inadequate. Many small holes form in compact bone that make the skeleton bone more fragile. Hip fractures is the commonest occur in osteoporosis. Secondly, as low bone mass density will lead to the bone more fractures, so that the bones cannot support the whole body properly. The one will easily fall down and brings out injuries, feeling of the pain. On the other hand, the abnormal shape of the bone growth also makes the one get into the chance of vertebrae collapse, heel-shaped backbone, and need the help of walking stick. Thirdly, as low bone formations will cause bone decrease in size, menopause is a stage to slow down the process of calcifications. The bone becomes brittle and not hard anymore. Besides, missing parts when building up is common, bone cannot fully develop. Lastly, the complications of fractures and causing death. Obesity will largely the pressures and frictions of the bone, of the joints and their collagens, ruptures, and the bones are attached directly, also cause painful. The hip fractures can increase the risk of the death of pulmonary embolisms, which cause PE according to many studies. When the bones cannot grow into a proper shape or length, the bone will cramp up and hemorrhage occurred. The situation goes worse, it cuts death and short by massive bleeding. Now I will pass to Ashley for more elaborations.
Let me introduce how to prevent osteoporosis. Regarding primary prevention, for diet and lifestyle, they should intake sufficient calcium. Since bone formation need them for putting down digestive appetite, which are both valuable. In order to promote calcium absorption in intestine and stimulate osteoblast activity, they should intake adequate vitamin D. Moreover, drinking alcohol and smoking should be prevented as they decrease osteoblast activity and bone formation. Avoid drinking alcohol is also beneficial to lower disturbance of developing pit bone mass. On the other hand, concerning exercise, they should do moderate weight-bearing exercise as it can stimulate osteoblast activity. For instance, walking, staring, climbing, and dancing. For secondary prevention, there are 3 scan tests to check your bone condition, including QCT, DXA, and QUS. QCT evaluates the effectiveness of bone mass theory and look for the bone mass. The purpose of DXA is measuring bone mineral density. The ND test is vital to development the bone density and virtual rates in the future. QUS is used to measure bone mineral condition in very few subclinical size. Let's pass to Grace to introduce how to treatment osteoporosis.
Sponsorly has a series of complicated bone anti-resorptive processes. It allows bone formation to work more effectively and improving bone mass. Firstly, it binds to hydroxy apatite crystals during the bone resorption. It interferes the production of osteoclasts. Those promotes the osteoclast apoptosis. It also prevents osteoblast apoptosis, so bone formation can continue for longer periods. SCRMS disturbs the production of osteoclasts as well as decrease the bone resorptive activity, decreases bone resorption and bone turnover, thereby increase bone density and decrease the risk of spine fractures in postmenopausal women with osteoporosis. Teriparatide and fortil of PTH can be considered for patients suffering from surgery osteoporosis. It's able to accumulate osteoblasts and activate their activity as well as prevent osteoblast apoptosis. It is worth to mentioning that PTH must intermittent administration because it facilitates the bone formation. In contrast, continuous administration brings the opposite effect that causes bone resorption. Calcitonin can reduce the concentration of blood calcium level by suppressing osteoblast activity in the bones and increasing the amount of calcium excreted in the urine. The hormone also prevents the absorption of calcium from the intestine, as well as increasing the calcium absorbed by the kidney. Now I will pass to Sally to talk about the conclusion.
Thank you, Grace. We have drawn some points for conclusion. First, the estrogen deficiencies cause osteoporosis after menopause. Second, KLOPG system mainly affect the bone metabolism. Third, the ratios of KL is greater than OPGL, which continuously increase the risk of osteoporosis. Fourth, the main clinical manifestations of osteoporosis are fractures and pain. Fifth, inadequate calcium intake and exercise or unhealthy lifestyle will cause the bone loss. Lastly, the drugs and physical therapy for long-term improvement of bone loss and reduce the signs and symptoms. So here are some questions for the Q&A session. Please try to due by several presentations. Thank you.